And now we're going to talk about extrasystoles. Although we talked about them in terms of supraventricular tachycardia, basically it's just the same. Supraventricular tachycardia means there are many supraventricular extrasystoles after each other. Okay, it's like 1,000 of extrasystoles, one after another. Okay. But now we're going to talk about a single extrasystole. And I'm going to compare the atrial ones with the ventricular ones. And just to be more clear, if I will draw the heart again over here, the thing what I mean by extrasystole means you're having a normal SA node, let's say. You're having a normal AV node and his bundle. And the thing what happened is SA node is giving the beat, and now suddenly cells from over here discharge faster. And this happens to all of us sometimes. It's nothing special. But if this happens in atriums, you call it atrial extrasystole or supraventricular extrasystole. It's the same. It's a synonym. If this happens in ventricles, you call it ventricular extrasystole. Okay? And I'll tell you 3 major points you have to know to tell a difference between a atrial extrasystole and a ventricular one. Okay, and so now we're heading to atrial extrasystole. And the 3 main things you should know is, first of all, if it's a atrial extrasystole, there's going to be a P wave. P wave is present, although the shape could be whatever. It could be negative, positive, doesn't matter. Okay, so P wave is present, whatever the shape is. Up, down, doesn't matter. The other hallmark is that QRS complex is normal. QRS complex is not wide, it's narrow, it's normal. Okay, and what does it tell you? If QRS complex is normal, it means that it happened in atriums, and then the discharge which goes through the ventricles goes normal, regular way. There's no problem at all. And last thing, which is most complicated for you, is that there is a incomplete compensatory pause. And what is that? Well, I will show you. So atrial extrasystole means preterm contraction. That's the same thing, contraction. So something triggered from the atriums that the heart contracted earlier than it should be. And how does it look like on ECG? Like this. I won't be drawing now T's, okay? So no T's. Okay? So guess which one is the extrasystole? Obviously it's this one, yeah? That's extrasystole. It's a preterm. This could be even negative or it doesn't matter, okay? But it's earlier. It's a preterm contraction, okay? And what is a incomplete compensatory pulse? Well, you see P over here, you see normal QRS, but incomplete compensatory pulse means if this is A, this is A, this is X, and this is Y, but in this case it equals A actually. And what means compensatory pause? Means if you multiply these two, normally this contraction should be over here at this place. But it's not. So this is incomplete compensatory pause. In a way, 2 times A is more than X plus A. Okay? Yeah? And I'll explain it more later. But remember, this is incomplete compensatory pause. And it's a third hallmark which confirms your diagnosis or guess that it's atrial extrasystole. I'll jump to ventricular extrasystoles. Okay? So ventricular extrasystole means there will be no P present. There will be QRS, going to be QRS. It's going to be bizarre, weird. Okay, I hope it's spelled like this. And third, there's going to be complete compensatory pause. Okay, and the thing how it should look on an ECG, I wonder if you'll guess which one is the extrasystole. No T's. I'm not drawing T's again. So which one is extrasystole? You're right, it's this one. And over here, complete means that this distance just equals this distance. It's exact on time. And basically, if I'll put A's over here, this is A, this is A, this is X, this is Y, and 2 times A equals X plus Y. Okay? And can someone tell me how come this is just on time? That this contraction just is on the time and that there is a complete compensatory pause. How come? What do you think? What happened? Well, if I'm going to draw the heart, the thing you should understand is, okay, here's the SA node, and here's the AV node. And, okay, over here, this is from SA node, normally. First starts here, sends it here, and then it goes normal way. Again, SA node starts normal QRS complex, again SA node. And now what happened over here? Well, some naughty cells discharged the ventricles earlier. So before the discharge from SA node could reach here, the ventricles were already discharged. Okay? But the point is, can you discharge it the other way? No. So basically what happened over here is, did SA node like discharge? Yeah. It's just hidden over here. Okay? So SA node was like beating like always, but because over here the ventricles got discharged from a different part earlier, then what happened is that the ventricles were discharged, and when the SA node, the depolarization reached the AV node, it couldn't go farther into ventricles because the ventricles were already discharged. Okay? Yeah? So basically, again, so this is like P is hidden over here, and again P. So that's why it's just on the time again, because for this case, it was discharged from the SA node again. Okay? Yeah? So that's why it's complete compensatory pause. Yep. In contrast to this, if we go back, what happened over here is, this is the atrial extrasystole. And why it is incomplete compensatory pause? Well, here's a P, here's a P, here's a P. But what happened over here is that, let's say, so here are the cells which discharged it, did the extrasystole. So what they did is they discharged pretermally the whole atriums, but they discharged also the SA node. Okay. So from over here, the SA node was discharged over here, and again was recharging or repolarizing the same time as normally. Okay. Yep. So it was discharged, and that's why this is A. This takes a time, the same time as over here and over here. Okay? Yeah? Everyone understand? That's why it's on incomplete compensatory pause. Okay? So if I will ask on the hemodynamics now, if you're going to have a, let's say, how much the ventricle will or ventricles will release when during this extrasystole, during this one, what do you think? Well, they will release less because they have less time to fill, so they release less. But during this normal contraction, they're having a normal time, and they will release or eject the same amount as normally, as over here or as over here. Okay? Yeah? It's like over here you're flushing earlier before the bucket is filled. Okay? Over here you got normal time. But in contrast to this, if we swap to ventricle extrasystoles, look at this. Over here, this is again, preterm contraction. So again, during the preterm contraction, the ventricles have less time to fill, so they're going to eject less blood. But over here, the Y takes longer. You have more time. So after the extrasystole, the ventricles will be filled even more a bit than usually. Okay, they got Y time. Y. This is more than A. Okay, yeah. So, but this is just the same, the complete compensatory as this one. So these, remember, these are the three hallmarks that will tell you this is. But the main one you should look for, of course, is the bizarre QRS complex. It tells you right away, oh, there's a problem in ventricles, not in atriums. Yeah? Okay? Good. So these were extrasystoles. And there is still terminology to them, and that is they could repeat. You know, it doesn't have to be one extrasystole, but it could be like every second beat, it could be extrasystole. And there could be like more places in the heart that are bad and will causing discharges. So let's say we're having a ventricle extrasystole. So the terminology would be like this. If this is a normal QRS, and then there is a bizarre, and there is another one, and again bizarre, you can say this is bigeminally binded or bounded or bounded, I don't know, bind it, I guess. Doesn't matter. You're gonna bind it. So every second, if every second is extrasystole, this one is normal, and this one is extrasystole. So this is bigeminically binded. If there would be every third one, you will call it trigeminically bonded. But what does the shape tell you of this one and this one? It tells you it's from the same place, that the discharge was from over here and it traveled the same way. So this one is monotopic. But you can have like two places. And then you're going to have this. Like this one. And then you have this one. And then you can have this one. And again, it always depends how it is. Okay, and then you have a normal one, and then you have this one. And now you have extrasystole here, and here, and here, and here. But because it has a different shape, these two, than these two, you know it's from two different places. That you know, first the SA node discharge, that's the SA node. Then let's say this one pathological one. It's like here 2 and 3. So this one is from 2. Now it's a SA node, and then is a 3, and then there is a SA node. Okay, and it turns. So this is bigeminically binded, bigeminically bounded, and plus it's polytopic. There are two places. So, and you can talk about the atrial or ventricular extrasystoles. Doesn't matter. It's the same. And one more thing, this is an important rule. If we talk about atrial extrasystoles, and if there are 3 after each other, so they're very near and there is no P, 3 and more after each other, you call it, and we talked about it already, it's atrial or supraventricular tachycardia. Okay? If you're having 3 or more, thousands, 10,000, doesn't matter, extrasystoles which come from ventricles, so ventricular extrasystoles, like this. This is a ventricular tachycardia. Okay? So remember, V-tach or A-tach or supraventricular tachycardia. Okay? And there is a major difference in the outcome and in severity and how dangerous it is. Because remember, supraventricular tachycardias, yeah, well, they could go fast, but it's sort of, the contraction of ventricles is okay. And they don't go so fast. So yeah, it's not so good, but if we compare it to V-tach, they're not dangerous. But V-tachs, those are so dangerous. Okay, of course it's always up to the speed. I mean, if you have a atrial tachycardia that goes 250, yeah, it's dangerous, of course, because the heart, the ventricles will have no time to fill. But this is not so common. But V-tachs, they can be really like 250 very easily. That's why those are so dangerous, because again, perfusion decreases, you're having heart attack or you have a syncope and something happens. Okay, so V-tachs are very dangerous, and we're heading to ventricles now. So we finished the extrasystoles, atrial versus ventricular, and now we're getting to ventricles. And exactly what we're going to start with? Well, we're going to start with ventricular tachycardia. Okay, so and ventricular tachycardia can be, it always depends how fast it is. If it has a speed of 150, it's okay. But if it has 220, no. When you had 220 last time when you were running, never. Okay, so this is so dangerous, and the faster the tachycardia is, the more dangerous it is. And of course, you won't be waiting at all. You're gonna do a cardioversion immediately. Okay, sure, you're gonna shock the patient. Okay, so remember, we're getting to ventricles. So ventricular arrhythmias, and first is a ventricular V-tach tachycardia. And remember that the frequency it's like from 140 till 220 per minute. And this could be very dangerous. So remember, if there are more than 3 QRS complexes, one after each other, you're having a, well, I'm exaggerating, but this is a V-tach. Okay. Even faster is and debatable, as I said, even faster, very debatable, and we don't know if we should, I don't know if I should mention it or not, but I will mention it. It's the ventricle flutter. Okay, and flutter looks like this. Okay, that's a flutter. It has a high amplitude, and the frequency really could be like, again, maybe 180 till 280. Doesn't matter, 250. But this is really fast. And still you can see R over here. Yeah, over here you can see also R. And remember, in case of, let's say, V-tach especially, and debatable, I will put it in brackets, V-flutter, you are still using cardioversion. What does it mean? You put the machine with which you shock, but the machine reads the ECG. And remember, you don't never want to send a shock when there is a T, because you could cause even a more severe arrhythmia. in repolarization. So basically the machine reads the ECG and it is still able to read it over here and over here. So it waits, it reads the ECG. When you push the button, it still waits. It shocks the patient during R typically. Okay, so you call this you call cardioversion. And with just the same machine, you also do defibrillation. Okay, this is in case you're having a V-fib, and this is a V-fib, and V-fib looks like this. You don't see any R's over there. It's totally like nothing. It's not a line. It's like this. And in this case, you defibrillate. Okay. So over there, when you when you push the button, it's just send it right away, the shock, because there are no R to be read. Okay, this is cardioversion. So remember cardioversion. Okay, but with the arrhythmias, remember V-tach, then even faster. Very debatable, we don't know. Ask cardiologists in the higher years if they still believe on flutters, ventricle flutters or not. Okay, and then definitely V-fib. Everyone believes on that. Okay. So, thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.